Welcome back to the Curious Clinicians, a medical podcast that asks why. I'm Tony Brew, and I'm joined as always by Avi Cooper. Hey, Avi, how are you doing?
I'm doing great. Good to see you.
Unfortunately, Hannah's not with us this evening. Hannah is dealing with 7 new consults, so she is actually being a doctor. But
important.
Exactly. We have a special guest on the show, not to replace Hannah. Actually, he was meant to join alongside as a fourth head, but Hannah's not with us, so I guess Giancarlo, you're kind of filling her seat. And it's a name I just mentioned. You've probably heard it before on the podcast. So Giancarlo Bonomo is here tonight. He's a fourth-year medical student at Boston University. He's usually a producer for the show, but for this episode, he's actually joining as a co-host. Giancarlo, great to have you.
Welcome.
I think the audience wants to know a little bit more about you before we hear what you've got in store. So tell us a little bit more about yourself.
Awesome. Thanks so much for having me on. It's a real honor. Hope I can maybe fill a quarter of Hannah's shoes at the best. So just briefly for everyone, I'm from just outside of Boston. I went to the University of Michigan for undergrad, so my teams have had very good years, let's just say. I'm an obnoxious fan times 2. I actually didn't want to be a doctor initially. I wanted to be a journalist. So after I graduated from college, I actually moved to Italy and worked as a freelance writer and reporter for a couple of years. I eventually realized I was better suited to medicine, so I came back to America, and now here I am, entering my 4th year of medical school. And I really love working for the Curious Clinicians because it honestly feels very journalistic. We ask questions, we dig through sources, and we craft it all into a story.
Very cool. And, Giancarlo, you've done a great job, really, I think, sort of elevating the game of a lot of our written content. Bringing your journalistic background. So that's really great. It's been great having you as part of the show. And so on that note, what question are you going to take us through tonight?
So something that I'm sure both of you have had a lot of experience with in your careers, and it's something I've already seen a couple times on the wards. The question today is, why do we use IV proton pump inhibitors to treat acute upper gastrointestinal bleeding?
Yeah, when you and I were first talking about this question, I think you reminded me that I was actually present when you first got introduced to this question. So I remember that story, but the audience doesn't. Can you tell us a little bit about what happened?
Sure. I'm going to leave out the part where I gave a completely wrong differential diagnosis and you very patiently walked me through why I was wrong. So I was on my medicine rotation and I went with my team to morning report. And the day's case was about a 50-something-year-old gentleman who came in with several days of abdominal comfort and black stools. And the chief resident is, up there with the whiteboard and says, okay, everyone, let's assume this is an upper GI bleed. What do we do? And then every single person said in unison, 2 large bore IVs, type and screen, IV PPIs, transfused to hemoglobin greater than 7. It actually kind of reminded me of that old McDonald's commercial where they sing the ingredients to a Big Mac. Avi, do you remember all of those ingredients?
Definitely not. Wasn't there something about like special sauce and a sesame seed bun or something? Or is that?
Yeah. There it was. I think it's 2 all beef patties, special sauce, lettuce, cheese, onions, pickles on a sesame seed bun.
So I guess the PPI is the special sauce.
Yeah. I mean, I don't know how far we really want to work this metaphor though. So maybe let's move ahead. And so I actually remember being really pleased with myself a couple weeks later because there was another morning report about acute GI bleeds. And this time I was able to, chant the management plan with everyone, 2 large bore IVs, type and screen, blah, blah, blah. But afterwards, I was sort of going through those steps and I asked myself, I said, what's with the IV PPIs? The large bore IVs made sense and the type and screen made sense, kind of like hemorrhage protocol. But I thought to myself, well, if we're giving PPIs intravenously, we must want them to work pretty fast in someone who, we're worried about them bleeding out. And, I assumed that it had something to do with like protecting ulcers or other lesions from more damage, kind of like a quote unquote, don't dig yourself a bigger hole idea. But as I read more and more, I realized that's not really the case.
Yeah, and one of the things I really like about this question is that GI bleeds are so common. And for me, they're particularly relevant because I'm an inpatient doctor, and GI bleeds are the most common GI complaint that leads to hospitalization. And as you mentioned, we often give patients IV PPIs, but I suspect many of the people who are doing that have never stepped back to ask, why they're actually doing that. What is the benefit of the PPI? But maybe before we get there, we've actually just this week have all these new interns. This episode is going to be released in a few weeks. There's going to be a bunch of new interns who may be listening, crossing my fingers, hopefully. It might be valuable even to go with a first step of talking about the initial standard management of someone who comes in with a GI bleed. So you maybe fill the listeners in a little bit about that, Giancarlo?
Definitely. So I think when someone comes in with, a suspected GI bleed, I think the big things you want to ask yourself are, where is this person bleeding from and how badly are they bleeding? The former is based mostly on symptoms. For example, someone who's reporting melena, that carries a likelihood ratio of between 5 and 6 for an upper GI bleed. And maybe someone who has profuse bright red blood per rectum, you might think, oh, this seems like more of a lower GI bleed. Obviously, things are a lot more complicated than that. If you have really brisk bleeding in the stomach, that can actually present as rectal bleeding. And you can have bleeding that's just proximal enough in the colon, for example, something in the right colon that can produce melena. So I think you really need to look at everything and just make your best initial guess about location.
Yeah, and I think when we're thinking about GI bleeding, right, like sort of knowing where be able to stop the bleed, put your finger on the bleed, right, like, that you get, so to speak, metaphorically, you got to know where it's coming from. So that seems like a really, important thing to understand.
Yeah, exactly, because where you're bleeding from a lot of time is going to determine both your diagnostics and also your treatment. For example, someone who has a really bad lower GI bleed, and endoscopy is not really going to help them. There are clinical calculators that you can use to kind of help you decide, is this someone who needs to be managed inpatient or outpatient? For example, for upper GI bleeds, actually, just the other day on the GI consult service, I calculated the Glasgow Blatchford bleeding score, GBS, for a patient. And it's just a list of factors, anemia, BUN, presence of melena, heart rate, blood pressure, and it just helps you assess, how badly, was this person bleeding? How big a risk are they of bleeding more? And do they need to be managed inpatient, or, could they just go home?
So it sounds like upfront what we're doing is making some attempt to localize the lesion, upper, lower, and then risk stratify. How bad is it, particularly if it's an upper GI bleed potentially. Let's imagine you got a resident who's admitting one of these patients. What's kind of like the next step in management? And you alluded to this a little bit earlier in the sort of rote response to the morning report question, but can you spell it out a little bit more?
You just want me to sing those steps to those steps again, don't you?
I've never eaten a Big Mac. As long as you do the GI bleed one and not the Big Mac one, I'm fine.
Okay, we'll do a separate episode that kind of unpacks that. But all jokes aside, it is that someone comes in with you think they have an upper GI bleed, they need inpatient management. You get IV access so that they can get IV fluids. You get a type-in screen. You transfuse them if necessary. I think regardless of the etiology, you need to keep the patient from bleeding to death. while people are getting those initial therapies, and they're getting prepped for an endoscopy, that's the point where most people get IV PPIs. Endoscopy is so useful in upper GI bleeds because it both can tell you exactly where they're bleeding from, and it can also be used as a therapy. You can cauterize lesions, you can clip them, you can do a lot of stuff. I will add that actually, according to the official American College of Gastroenterology guidelines, there's actually no recommendation that the PPIs be used before endoscopy. But we're actually going to talk a little bit more about that later.
Okay, so we're back. One quick clarification, Giancarlo. Are we talking tonight about why like IV versus oral route of administration in acute upper GI bleed? Or are we talking about like sort of the drugs themselves, why we use PPIs in acute upper GI bleed?
No, thanks so much for asking that. We're not really discussing IV versus oral. We're really just discussing why PPIs for acute upper GI bleeds.
Okay, cool. And so if we think about, peptic ulcer disease, that's right. That's, I think, the most common cause of upper GI bleeds. And, I guess sort of what causes ulcers then? Like what are we dealing with when a patient comes in with a bleeding ulcer?
So most ulcers can be linked back to one of two causes: H. pylori infection or NSAID use. We could honestly do an episode on each of them, but I think going over the mechanisms of them will be really important to understanding why we do and why we don't use PPIs for these acute upper GI bleeds. So, Tony, put you on the spot. How do you think H. pylori causes ulcers?
Well, we're talking about PPIs this episode, and they do something with the proton pump. And so I'm going to guess it has something to do with alteration of the gastric pH. That's my guess.
Good guess. So H. pylori definitely can alter pH, but that's actually not the root mechanism. H. pylori can raise or lower gastric pH, but in the majority of cases, it actually raises it.
Okay, so riddle me this: if it's raising gastric pH, so the stomach is less acidic, why would H. pylori cause ulcers? Like if acid is the problem, shouldn't ulcers be less likely if the pH is less acidic?
I thought that too. And when I was researching this episode, I really read this paper like 5 times in a row to make sure I hadn't completely, misunderstood it. But it turns out that ulcers really form from mucosal damage. In the case of H. pylori, it's a bacteria. It's burrowing into the mucosa, and the body's chronic inflammatory response eventually damages the mucosa, which then exposes the underlying tissue to harmful gastric contents. I guess to use an analogy, it's a little bit like how people with eczema get these like superimposed Staph aureus infections, but Staph aureus isn't the cause of eczema in the first place.
So basically, it sounds like even with a less acidic stomach with H. pylori infection, it's still pretty darn acidic. And with the mucosal damage and stuff that you're getting from the chronic inflammation related to the infection, it can still harm and erode the stomach wall.
Exactly.
Summary.
Exactly.
Okay.
Exactly.
It certainly ain't helping.
Yeah, I mean, once you damage that mucosa, a slightly more alkaline environment, is still not going to be that friendly.
Okay, so H. pylori induces inflammation. That I buy. But you mentioned, and I think we've all learned, that NSAIDs are the second major cause of peptic ulcer. And obviously NSAIDs are anti-inflammatory. They, like, literally, that is in the name.
I can assure you, in my first couple of years of medical school, I also learned that.
Yeah. So it's going to be hard to invoke inflammation as the mechanism with NSAIDs. So, like, what's going on there?
Yeah, again, it's this very surprising thing. So COX-1 is an enzyme in the gastric mucosa, and it produces prostaglandin. Prostaglandin, which is something that helps produce inflammation, but in the mucosa, it helps regulate mucosal blood flow. A lot of NSAIDs inhibit COX-1, and this disrupts mucosal blood flow and eventually, damages the mucosa. So there's actually a study, and it took around 8,000 patients who were on chronic NSAIDs for rheumatoid arthritis, and they gave half of them, a 6-month course of misoprostol, which is a synthetic prostaglandin. A lot of us, learned about it in the setting of obstetrics. Compared to the control group, who didn't get any additional therapy other than their usual NSAIDs, the misoprostol group had 40% fewer GI bleeds.
Okay, so the mechanism there with the NSAIDs is more related to inhibition of prostaglandin synthesis, and I guess it then makes sense that the NSAIDs that have a proclivity for inhibiting COX-1 in particular are the ones that we tend to avoid in upper GI bleeds. So the ones like ibuprofen, naproxen. Am I getting that right?
Yeah. That's definitely kind of the way the logic flows, like at least kind of in clinical practice. I think the actual mechanism may be a little more complicated. There was one study where they took rats and they gave them, these various combination of NSAIDs, including, ketorolac, which is very COX-1 specific, and celecoxib, which is COX-2 specific. And celecoxib is sometimes invoked as like, oh, if you're worried about bleeding, give them celecoxib. Only the rats who received both of them had significant gastric damage. The rats who just got ketorolac actually did not have significantly different rates of gastric damage. And I think the proposed mechanism is that COX-2 allows for leukocyte adhesion, and it's this combination of impaired, mucosal integrity from inhibiting COX-1 and impaired healing from inhibiting COX-2 that really propagates an ulcer.
Okay, so if we were going to zoom out, it sounds like maybe the main takeaway for most ulcers, it's not that people are making too much acid, but rather there's been sort of some breakdown of the mucosa, and then the stomach acid is not, like you said, it's not helping, and that may contribute to subsequent damage. So I guess if acid isn't the primary problem, why are we using PPIs for acute upper GI bleeds if like the mucosa's already been, we've already got a mucosal problem and that's the main issue?
Yeah, I mean, that's a really good way of putting it. If you have a bleeding ulcer, some PPIs are not going to make it instantly heal. But if we take a step back, in the case of an acute upper GI bleed, what do we really care about? It's the bleeding. And that's actually what the PPIs are helping with.
And my assumption is going to be that they're helping via their alteration of gastric pH, meaning the raising of the gastric pH.
Exactly. It all comes down to how pH affects blood's ability to clot. It turns out that acidity can dramatically affect how your coagulation factors and your platelets function. There's kind of an early study from the late 70s where they took these individual blood components from patients and they exposed them to progressively lower pH environments, just like in petri dishes. And when you dropped the pH of the environment in the petri dish from 7.4 to 5.9, platelet aggregation virtually ceased, and PT and PTT were both extended. And mind you, 5.9 is a lot higher pH than you actually see in the stomach.
I feel like you've attempted to put out a bat signal to Hannah with the invocation of like hemostasis. Something tells me she's suddenly going to appear on the episode. She's still working on her 7 consults.
Did someone say PTT?
Exactly. Yeah.
Well, I guess that's sort of not necessarily surprising to me as an intensivist. Especially this comes up in the trauma literature, talking about the triad of death: hypothermia, acidosis, coagulopathy. Certainly anyone with really very severe, sort of very brisk bleeding and hemorrhagic shock can sort of develop that triad and stuff stops working. So how do we know how low pH affects, like, why it's affecting clotting?
We know a good deal, but we don't know everything. I think it's probably easiest if we split this up into clotting factors and platelets, because the mechanisms for those seem to be a little bit different. For clotting factors, I think it's not entirely clear how it works, probably because the coagulation cascade involves, so many factors, pun intended. um, Avi, just for all of our listeners, would you mind giving us kind of a quick refresher on what exactly the coagulation cascade is? Sorry to put you on the spot again.
I'm not. I'm a poor stand-in for hematologist Hannah, but my sort of very basic understanding is that basically the goal, right, is to plug the hole, and so and it starts with a platelet plug and it ends with a clot and a thrombus, and so basically the platelet plug starts when there's been a rent, a rip in the damage to a blood vessel, exposure of sort of the tissue and stuff. There's exposed sort of submucosal tissue, and then that causes the platelets to basically to adhere, to activate, and then they start releasing sort of procoagulant stuff that basically sort of helps the coagulation cascade gets going. You get a platelet plug that's really sort of not very strong, and so you need that strength of the clot, and so the platelets activating sort of helps kickstart the various parts of the coagulation cascade, which really is like a chain reaction, where each one is active, each factor is activating the next one, ultimately with the goal of turning, of basically activating thrombin, so that thrombin can cut fibrin out of fibrinogen. And then once you've got, activated fibrin there, then they have these little hooks and grooves and stuff, and it sticks together, and you build a strong clot where the platelet plug has been. So.
Oh, thanks so much for going over that. And, from your explanation, it really becomes clear how there are so many different, bleeding disorders, because there's so many steps at which this can go wrong. Yeah. And, if I understood you correctly, what you're saying is the coagulation cascade is really a cascade of reactions. And, each reaction has a product which acts as the catalyst for the next one. And they just kind of keep going down, boom, 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 activating each other. And, if we think back to just kind of, our high school chemistry, catalysts, the rate at which they work is oftentimes dependent on external factors like temperature and pH. And the coagulation cascade, from what I've read, is really no different. For example, if you reduce pH, just from 7.4 to 7, the rate at which the factor 10A, factor 5A complex in the coagulation cascade activates prothrombin, and prothrombin is what is going to eventually become thrombin, that will be reduced by around 70%.
Wow.
And this is the kind of reduction in pH that Avi sees all the time, or cares for once they get down to 7.0, right? It's not uncommon for you to see a pH of 7.0 in your ICU. And the idea that going from normal 7.4 to 7.0 drops these complexes by 70% is pretty dramatic. I suspect there are other effects given the fact that there's so many darn pathways and factors.
Oh yeah, people have studied this every which way. There was one study I found which was really interesting. So it was in pigs, and the researchers, they gave them infusions of hydrochloric acid, which obviously made them, uh, acidotic, and then they corrected their serum, pH just with a bicarbonate infusion. So they dropped the pH and then they brought it back up, and they tested their coagulation times both before the acid was infused, after the acid was infused, and then after the bicarbonate was infused. And they found that even after you infuse the bicarb, the coag times didn't actually normalize. And what this implied was that the acidemia wasn't just affecting enzyme kinetics, because theoretically, if you affect the enzyme kinetics with, by lowering the pH, but then you return the pH to a more favorable state, the reaction should sort of return to its normal rate. And that's not what they saw. So the theory was that there must be some sort of irreversible change going on. And then there was a similar study where they also did the same thing, gave pigs hydrochloric acid, except this time they decided to study fibrin, which is that material that Avi was talking about. So normally, fibrinogen is converted to fibrin, that cross-links together, that helps form the clot. D-dimer is a protein fragment that's shed from blood clots as they form and they break down, which is why it's used sort of as a test for pulmonary emboli. In this study, the acidemic pigs had decreased fibrinogen, but there was no accompanying increase in fibrin synthesis, and there was no increase in D-dimer. So what this meant was that this acidosis was somehow causing a breakdown of fibrinogen without taking the fibrinogen and turning it just into blood clots.
So, I mean, from what you've just described, again, it seems as though the effect of pH isn't just on like a single factor, like tissue factor or factor 7. It's on multiple different places in both the coagulation cascade and potentially even in the fibrinolytic section of hemostasis. But you mentioned right at the top that there's coagulation and there's, as Avi mentioned, that initial platelet plug. So what happens with platelets as pH drops?
That mechanism is better understood. There's a really extensive study from 2012 which measured platelet aggregation. Aggregation is just what platelets do. They form a platelet plug at normal pH 7.4 and lower ones of 7 and 6.5. And they found that acidosis disrupts aggregation at a lot of different levels. So alpha 2b beta 3, a mouthful, but it's the integrin, the surface protein that platelets use to bind to each other. Under acidic conditions, its conformation has changed, so it's not able to help platelets stick to each other as well. Platelets also have these calcium-dependent pathways inside of them that they use to release dense granules and thromboxane A2. Acidic conditions disrupt those pathways, so they're less able to signal to each other. And then thrombin, that member of the coagulation cascade, is also an activator of platelets, and under acidic conditions, it also has lower activity because its calcium-dependent signaling is disrupted.
Very cool. I mean, it's sort of striking, how these very not huge changes in pH can cause a really big effect, especially on the platelet part of the equation. So, okay, so we've established that acidic conditions are not good for clotting. So I guess, we've talked about PPIs with ulcers here. It sort of stands to reason then that regardless of the cause of the upper GI bleed, the PPI, raising that pH should be a good thing, right? Or is that, what's going on with that?
Yeah, I mean, if you think that, acid is affecting bleeding, a PPI will help. But I think we need to go back to what you were talking about earlier about location. So IV PPIs, are only going to work on gastric parietal cells. Um, so they're really only going to affect pH, and therefore bleeding in the stomach and first parts of the duodenum. So I think this brings up kind of an interesting question, which is that if you don't know the etiology and location of a GI bleed, should you just hold off on giving the IV PPIs? This is actually something Tony has discussed before, so I really love to hear his thoughts.
And you made reference to this a little bit earlier when you mentioned that the guidelines are somewhat agnostic about pre-endoscopic PPI and upper GI bleed, which I think would surprise a lot of listeners. They would assume this is like a 1A recommendation. Um, and when Giancarlo is referencing is a talk I give in the Things We Do for No Reason series, and that series is published in the Journal of Hospital Medicine. And in that talk, I actually argue against giving PPIs before endoscopy. And my main argument is that not all bleeding, not all upper GI bleeds are from ulcers. It's the most common, but it's not all of them. And that some of the other non-ulcer causes, for example, esophageal varices, they don't benefit from PPI therapy. And there's a Cochrane meta-analysis that kind of supports the idea that pre-endoscopic PPIs, um, specifically if you look at patient-centered outcomes like rebleeding and the need for surgery, they actually don't help. Meaning, pre-endoscopic PPIs don't reduce the risk of rebleeding, don't reduce the need for surgery. And the problem is that because you start a patient on a PPI, it's so hard to tear it off, and it ends up being a medication that gets prescribed for months and sometimes even years after that initial event. And PPIs obviously have a lot of side effects. So the argument in this talk I give is what matters more is giving the PPI post-endoscopy to help with the ultimate downstream healing. But I really do want to acknowledge that everything that Giancarlo's mentioned to this point um, does play out in the data we have. If you look at the benefits that patients receive with pre-endoscopic PPIs, it is that they reduce signs of bleeding at EGD and they reduce the need for endoscopic therapy. So it kind of fits within this idea that what they're doing is they're helping with hemostasis. Um, but it unfortunately doesn't mean they're helping with rebleeding rates pre-endoscopically or with surgery. But the endoscopist is seeing, they're not actively bleeding at the time that I'm doing the endoscopy. And so for the endoscopist, it's a good outcome. For the patient, it's hard to tell.
So I certainly for me in the ICU, our threshold to do stuff like giving PPIs, even if there's uncertain benefit, it's low. But Tony, I think you make a really good point about not continuing them if it's clear that there's an indication that they're not benefiting. There's no reason to expose the patient to that. But I guess thinking specifically about something like varices, where we do use PPIs, but they're probably not helping much. The mainstay of therapy is to bring the portal pressures down with something like octreotide, and then we band the GI, the endoscopist will do banding to sort of close off the varices, and then using a TIPS, right, to really sort of if it's refractory to decompress the varices. So it's interesting to sort of think about which indications our PPI really going to benefit, acknowledging all of the effects on hemostasis that you've talked about tonight, Giancarlo.
Yeah. And, specifically with, varices, I'm glad you brought that up because I think one of the difficult things about, thinking about upper GI bleeds and GI bleeds in general is that, upper versus lower, you can tease out with symptoms. Variceal bleeding is maybe distinctive because of the sort of, profuse, hematemesis. But for a lot of stuff, it's not really that clear, like precisely, is it stomach? Is it duodenum? Is it, jejunum? Is it right colon? A lot of times you just discover that stuff when you do an endoscopy or colonoscopy. And the reason I'm mentioning all this is that, obviously the use of PPIs to treat, bleeding ulcers is very well documented. There's a lot of good literature on it, but there's not really a lot of studies discussing, the use of PPIs for other causes of GI bleeding. For example, portal hypertensive gastropathy, which is, an effect of increased, portal pressure. There was actually a study from China where they took patients who were bleeding from portal hypertensive gastropathy, and they gave them either octreotide, vasopressin, or just omeprazole. Omeprazole was actually almost as effective as vasopressin in controlling bleeding. I think it was like 59% of patients receiving omeprazole had bleeding that ceased, and 64% of patients receiving vasopressin had bleeding that ceased. And then when they scoped these patients, the majority of them not only had dilated capillaries in their stomach, but they also had mucosal erosion, which kind of implied that maybe cirrhosis, which was giving them increased portal pressure, and portal hypertensive gastropathy was also predisposing them to ulcers. So you may think at this point, kind of, going back to the previous question, well, if they definitely help with ulcers and they, maybe help with this other less common thing, should you just kind of, give everyone PPIs if they're acutely bleeding? But actually, there are studies that show that, PPIs can increase the risk of lower GI bleeding. The mechanism, they think, is that by altering, the upstream pH, that then influences the downstream pH enough that you have altered gut flora, and this can lead to inflammatory changes and ultimately mucosal damage. But I think we're kind of getting really into the details there. I think the bigger lesson here is that if you have a patient who comes in with an acute GI bleed, and you think that acidic conditions are in some way worsening their bleeding, PPIs most likely will be helpful.
Well, I also think the major message is that if you pay attention in morning report, you'll be able to recite the recipe for upper GI bleed, because you were able to do it multiple times, it sounded like, over a short
way better than I could do the Big Mac.
You basically couldn't do it at all.
One thing I just wanted to correct something that I said earlier, just about sort of what the physiologic goals are in terms of variceal bleeding and stuff, right? And so the octreotide, I misspoke. What we're trying to do there is really sort of constrict the splanchnic arterioles to reduce inflow into the varices, and so that's in sort of the portal circulation. So it's that's really more what it's doing. So wanted to correct that before we wrap.
I think the fact that you know that and not the Big Mac song is a really good sign.
Yeah, you do work in the intensive care unit, not at McDonald's. So
I was like Tony, I also have never had a Big Mac. So
yeah. Well, Giancarlo, you kind of took us through everything related to upper GI bleed. Were a fantastic stand-in for Hannah. Avi, although I would say you were a stand-in too, because you took us through the coagulation cascade without missing a beat.
Yeah, I'm sure there'll be something I missed.
Yeah, there's no way there that we didn't. But why don't you give us some take-home points?
Sure. So I would say number one is that the majority of upper GI bleeds are caused by ulcers, and the majority of ulcers are the result of gastric mucosal damage from either H. pylori or NSAID use. Then the second take-home point would be that the acidic conditions of the stomach and the duodenum impair clotting ability, by inhibition of platelets and coagulation factors. And then finally, IV PPIs are primarily used to aid in hemostasis for acute bleedings in acidic areas.
Very cool. Thank you so much, Giancarlo. That wraps up another episode of the Curious Clinicians. Thank you as always for joining us. Claire Morgan of notearly.com is our audio editor, and Giancarlo Bonomo, who joined us tonight on the show, is a producer for the show. And so you can join our mailing list at curiousclinicians.com to stay up to date on episode releases and have detailed notes delivered directly to your inbox. You can subscribe to our Substack at thecuriousclinicians.substack.com. And you can watch a video of this episode on our new YouTube channel, The Curious Clinicians Podcast. Physicians and other healthcare professionals can earn CME and MOC credits from VCU Health just for listening to the episode. For more information, visit ce.vcuhealth.org/Curious Clinicians. And as always, the information contained in this episode is for educational and entertainment purposes only and does not constitute medical advice. Until next time,